First of all, it's a pleasure being here, and thank you very much for having me. I'm resident Delia Metat from Department 14. This is a 59-year-old gentleman who first complained of a right acute diminution of vision 5 weeks ago. He was diagnosed with inflammation inside the eye elsewhere and was given systemic and topical treatment, including Optipred and Nevanac. He was also given intravitreal injection of unknown substance about 3 weeks ago, followed by a black curtain that developed 3 days ago. This was his ultrasound before IVI. It showed mild vitritis and the retina was in place. So we thought maybe it seemed like uveitis. But then when we examined the eye, it showed a visual active hand motion back projection. The AC was quiet. He had a subtotal retinal detachment with multiple rarefied areas of the retina and multiple retinal breaks. So where is the inflammation, and how is that linked to his rhegmatogenous detachment? On examining the other eye, he had a visual acuity of 0.1, stellate KPs, flareon cells +1, vitritis +2, and multiple focal peripheral pale areas of the retina, suggestive of retinitis. This is his actual fundus photography. It's very hazy because of the vitritis. However, we can appreciate the peripheral pale areas of the retina, suggestive of retinitis. This is an online picture demonstrating the peripheral retinitis that later develops into retinal necrosis, as we will explain later. So the decision was the right eye was for poor prognosis and that we should focus on the left eye and refer it to the uveitis clinic. I'll just briefly touch upon the topic of retinal necrosis. It's split into acute retinal necrosis and progressive outer retinal necrosis. ARN is due to HSV, which is usually in younger ages, whereas the older ages are usually affected by varicella zoster virus. PORN is usually caused by varicella zoster virus, and it's usually in immunocompromised patients. In this case, we will focus on ARN. So acute retinal necrosis, I would like to emphasize that it's a very rare case we're talking about here. It's about 0.5 to 0.63 new cases per million with a very poor visual prognosis. So it's split into acute herpetic and late cicatricial phases. The acute herpetic phase is characterized by viral particles in the retina. This results in an inflammatory response and panuveitis. This then results in retinal arteriolar inflammation. The arteriolar inflammation results in vasoocclusion and consequently retinal necrosis. The cicatricial phase is characterized by contractile membranes on the vitreous. This results in multiple retinal holes and tears at the junction of the normal and the atrophic retina, resulting in rhegmatogenous detachment. This occurs in about 80% or 70% of cases that are untreated and up to 50% of treated cases. So we can say that the first eye he presented with lies within the late phase, given rhegmatogenous detachment, whereas the other eye lies within the acute herpetic phase, given the peripheral retinitis lesions. And the progression from one phase to the next usually occurs only within a few weeks to months. So the mission was to save the left eye. We did an aqueous tap that was positive for varicella zoster virus, and the patient was given oral acyclovir, IVI, ganciclovir, topical plegica, and 3 weeks after the retinitis improved, he was added on systemic steroids and topical Optipred. Follow-up 2 months later, he had a visual acuity of 0.3, he was previously 0.1, and a flare only plus 0.5. He still had vitritis, but there were no peripheral retinitis. Seems like a happy ending, right? Well, actually, this was the last slide on my presentation 3 weeks earlier. However, unfortunately, the patient developed retinal detachment, and his visual acuity dropped to 0.16. He had a vitritis of +1, inferior rhegmatogenous detachment with multiple breaks inferiorly, just like the other eye. So the next day, immediately, he underwent vitrectomy, silicone injection, and laser 360, central to the rarefied retina by our dear professor, Dr. Ayman Khattab. And his visual acuity best corrects now to 0.1. The retina is in place, silicone oil-filled globe, laser marks 360. These are my references. I'd also like to emphasize that the medical treatment was given under the supervision of our dear professor, Dr. Baha Yusuf. And thank you very much.